Well, I would like to talk with you today about medication side effects, and as I say here, how to spot them and what to do about them. This is going to, and I'm going to try to make this all in about 15 minutes, so it's a big topic. I'm going to try not to talk too fast, but I do want to cover this stuff because it is pretty important. Also, FYI, there we go. I'm going to cover, oh, I take this back. I'm not going to cover today how medications work. That was my initial draft, but we'll have to save that for later. I'm going to talk about the major categories of medication side effects, and I also apologize because I'm using a new slide sharing system, so I'm regaining my orientation here. So I'm going to talk about major categories of side effects, and I think this is an important topic because partly my chosen profession of psychiatry and medicine in general keeps coming up with bizarre esoteric names, and in some cases names that are so vague, like metabolic side effect, as to not be really readily obvious to almost anybody. Like when I say a metabolic side effect, what does that mean? Well, it means weight gain primarily. So because the names are confusing, I'm going to explain these things in basic English language. And I think it's important because the more we know about side effects and the more we realize that side effects are supposed to be a relatively uncommon occurrence, and if they occur, they can be treated, medications can be changed, or things can be done to prevent them. It is at least theoretically possible to treat somebody with antipsychotic medications and have either no side effects or minimal side effects that are easy to trade off for significant therapeutic benefit. But we're not going to know about that or achieve that goal unless we really keep that close to front and center. And it is, I don't think we have a good data on this, but from comments that I read in online fora where people affected by psychosis gather, there is enormous reluctance to discuss side effects with medical people. From what I read and hear from folks, there are two possible things. One is that they feel that we're going to be upset at them, or that we're going to change them to something worse, or in other cases, they might not be fully aware of what they're experiencing as a side effect, which itself can be treated. And I think I'm going to speak to this audience, which is primarily non-physicians or non-prescribers, because you guys are probably more important in achieving this goal, since patients spend more time with you than they do with the likes of me. And because I'm one of the people who, because of my position, I might be more intimidating to a client, and where other people who spend more time, that sort of professional versus client relationship becomes more egalitarian. So you are more likely to hear about side effects and will be in a better position to notice them as well. So let's then, with that as a background and rationale, let's just jump into explaining the side effects as clearly and quickly as I can. You can parse them in two ways. You can talk about the system that's affected, or you can talk about the time frame. Are they happening pretty soon after you start the medicine, or do they happen as a consequence of longer term exposure? Longer term exposure onset, we call that tardive or late onset, and early onset or happening shortly after you started medicine is called an acute time frame. And many of the side effects are neurological, and we call them extrapyramidal. I'll explain that in a second. There's one key side effect which involves the endocrine system, and that is with elevated prolactin levels. And then we have that family of things with the kind of vague name metabolic. We're talking primarily weight gain, but also impacts on the body's ability to manage blood sugar and fat levels in the blood. So I'm going to talk about each of these systems, and I will point out that extrapyramidal side effects can happen both acutely or tardively. Endocrine side effects usually happen acutely, and metabolic side effects can happen anywhere between acutely and later onset. So that's that. Let's move on now to extrapyramidal. What in the world is extrapyramidal? Well, there's a part in the brain, and here on the human skull is illustrated in green. It's called the pyramids of the medulla. And on the far right, there's actually a picture of a human brainstem of a medulla. And these kind of long, skinny things, if you look at them at a certain angle, you can vaguely see that they're a little pyramid shaped, more like in cross section. But these are called the pyramids, and they're important because if I have a thought to move my body, a part of my body like my arm, that thought travels from the motor strip of my cerebral cortex through the pyramids down to the muscles. It follows the pyramidal tract. But there are other forms of movement that, for example, muscle tone or coordination, that use circuits that don't pass through the pyramid pathway, that don't pass through the pyramids. And we call those then the extrapyramidal, the extrapyramidal circuits. And extrapyramidal movements are involved in muscle tone or coordination. That's all that means. So extrapyramidal symptoms, again, involving tone or coordination primarily. The extrapyramidal symptoms is a group, it's a family. And I'm going to then parse down each one of those specific subtypes within the extrapyramidal family. Dystonia means bad tone. It means, that's the literal translation of dystonia. It translates into clinical practice into stiff muscles or cramping, and they can range from just stiffness to outright painful cramping. It can occur in any muscle group. It can occur in the muscles of the eye, which is painful and scary, and it can involve the muscles of the throat or the tongue, which can lead people to sometimes have difficulty swallowing or difficulty articulating their speech. So in my consultation, which is primarily hospital practice, where people tend to use higher doses of medicines, it's not uncommon for me to hear, we can't really understand what so-and-so is saying because he garbles his words or he seems to slur his words. And in many cases, if not most of them, that's because they're giving him dystonia of the muscles of his throat or his tongue. So I mentioned those because we tend not to think about throat and tongue or eye muscles as affected by dystonia, but they actually can be. So that's dystonia. Akathisia, there's some debate as to whether we should truly call this an extrapyramidal symptom, but tradition says that it is. This is a feeling of intense restlessness. In the textbooks, it said like a feeling that you have to move, and it goes along with the sort of compulsion to move or to fidget or to pace. It's also important to realize that akathisia can be a purely subjective experience. It can just be an emotional experience. It doesn't have to necessarily be translated into actual physical motion. If you ask somebody if you feel uncomfortable, I sometimes say, some people say that they feel this way and it feels like they want to crawl out of their skin. And like people just like pound the table and say, yeah, that's exactly what it feels like. So people endorse that as a metaphor for the feeling of it. And I've actually have colleagues who have been given anti-nausea medicines, and many of those medicines also share this akathisia side effect. My colleagues who are very articulate people say there really is no word in our language to describe this kind of internal discomfort. So, it's easy to say, I feel agitated or I feel anxious. And indeed, in many cases, clinicians will treat people with anxiety medicines or more antipsychotic medications to try to address anxiety or agitation. But as always, if you hear that, worthwhile to ask about crawling out of your skin feeling, and just keep an open mind or a suspicious mind about whether the person is experiencing akathisia. I elaborated on this because this is actually a very frequently missed side effect, a very uncomfortable side effect, and it can lead to a lot of behavioral disturbances, which then also not infrequently get mislabeled or misrecognized and mistreated. So keep that in mind, and people will be thankful. Moving on with the next in the category of the extrapyramidal family of symptoms. In the box, all these bullet points, every single one of these is a feature of so-called drug-induced Parkinsonism, also known as pseudo-Parkinsonism, which means false Parkinsonism. So it's not Parkinson's disease proper, but the actions of the drug mimic the physiology of Parkinson's disease. And you can get literally every symptom of Parkinson's disease simply as a side effect of typically too high of a dose of antipsychotic medication. These involve a tremor, and the tremor of drug-induced Parkinsonism or of natural Parkinson's disease is very rhythmic, and it happens about 3 beats or 3 cycles per second. Bradykinesia means slow moving, and so people just move slowly, like the name says. People with Parkinson's disease tend to have a stooped posture. They, they're bent a little bit forward with their head down. They tend not to have, they have a shuffling gait. They don't have a lot of movement of their feet when they're walking. Sometimes that can translate in the end to sort of a running gait, so you can move from shuffling to running. That's called festinating gait. But usually you see it in the form of shuffling gait and reduced arm swing when people walk. They'll have their facial expressions won't be reduced, and that will lead us as psychiatrists to think, oh, they have reduced affective expression. They might actually just have Parkinson's disease or drug-induced Parkinsonism because they're not smiling or moving their facial muscles so much. And also you can have difficulty getting out of a chair or out of a bed. So those are the symptoms those are extrapyramidal symptoms, and these all belong into the family of drug-induced Parkinsonism. Tardive dyskinesia is, as the name implies, tardive. That is by definition a late onset occurrence. Dyskinesia means literally bad motion or abnormal movements. It can occur in any muscle group throughout the body. It's kind of initially well known for muscles of the face. So you can have lip smacking, tongue thrusting. Oftentimes there's, you can see like a tongue protruding in the cheek. There can be a sort of chewing motion or lip smacking that sort of reminds people of the way that rabbits eat, so they call that rabbit syndrome. And then aside from muscles of the face, you can also have a kind of a jerky or a writhing movement in fingers or toes, arms or legs, or the torso, or even the neck. So that's what it looks like. It's different than 3 cycles per second tremor. And it can be the case that if a patient discontinues his or her medicine, or self-reduces the dose, or if the doctor reduces the dose, that you'll start to see these symptoms emerge. So that's a little bit about the behavior of TD. I want to also talk about, and by the way, every single one of these symptoms I'm describing is a consequence of blocking the signal for dopamine. And also a consequence of blocking dopamine signal is something that looks like the negative symptoms of schizophrenia, but actually is a medication side effect. We call this a secondary negative symptom. So negative symptoms, as I think you know, involve decreased emotional expression, decreased emotional experience, what we would label, I think incorrectly, restricted range of affect, and so forth. And this is really tricky because schizophrenia by itself, in some cases, in some patients, can have this as part of the illness itself, but you can also get it as a medication side effect, and the symptoms look exactly the same. So that's a tricky thing, but it's something to keep in mind. Another, and I think the last of the consequences of dopamine receptor blocking that I'm going to talk about, is elevating prolactin levels. Prolactin is a hormone secreted by the pituitary gland. Dopamine is actually a signal the brain uses to keep prolactin levels low. And then if we block dopamine too much, or if we block dopamine with certain kinds of medications, we remove the natural brake, take the foot off the brake, and then you wind up with a pituitary engine on and secreting prolactin. And that can translate into, for women, changes in menstrual cycles, resulting in fewer menses or no menstrual cycles. In men, that can translate to lower testosterone levels. In either women or men, this can translate into breast enlargement, breast tenderness, and sometimes milk production. And in either gender, you can have changes of sexual interest or sexual performance. It also contributes to osteoporosis. And every other symptom I've talked about, you can ascertain by observation and these are some of the symptoms that I mentioned, but it's much easier, and you can detect it earlier by simply doing a blood test from time to time. So those are the dopamine receptor signal interference consequences, and I'm going to talk about how to prevent them in a few slides from now. Metabolic side effects, again, we're primarily talking about weight gain, which can progress to obesity. It can be either a secondary to the weight gain or independently of changes in weight. We can also see changes in insulin responsiveness in the body, and that can translate into high insulin levels. In extremely rare cases, you can have extremely high glucose levels, which can then necessitate a trip to the hospital. Super rare, but still can happen. And along with those, or in that family, are changes of triglyceride or cholesterol in ways that can contribute to increasing the risk of heart disease and thereby reducing lifespan through cardiovascular complications. So it's a serious set of side effects. And now I'm going to talk about what to do about them. So for starting again with the dopamine, the consequences of dopamine blocking, first we talk about dystonia, the muscle stiffness or cramps. It's really, really easy to treat. You give them a kind of a low dose of a kind of medicine that blocks the muscarinic acetylcholine receptor. You don't have to memorize that. That's not going to be on the quiz. But you've probably heard of the name Cogentin and Benadryl. These two medications at relatively low doses can very rapidly get rid of dystonia. You can, a person could prescribe them on an ongoing basis. I am not at all a fan of that because you invite other side effects. But in some cases, it may be a choice. Or it may be desirable in certain circumstances. We can also simply lower the dose, switch to other medicines, and as I said, sometimes just co-prescribe that medicine or use it as needed if you have another occurrence of it. So there are options for that. Drug-induced Parkinsonism, we can use, again, the same kind of medicines, Cogentin or Benadryl. Those are useful in treating drug-induced Parkinsonism. Again, tremor, slow moving, reduced muscles of facial expression, and that sort of family of symptoms. There's also a very, very interesting medicine, hardly used anymore, but it really ought to be considered more. Its generic name is amantadine. It went by brand names as Simitrel, and there's actually a patented or on-brand form called Gocovri these days. This is more like a mild pro-dopamine medicine, so you can avoid anticholinergic side effects, and you can sort of maybe more directly normalize the dopamine signal a bit. Amantadine is quite useful for this, and so I mentioned that. I mentioned it twice because, as I said, it's a bit underutilized. And you can also simply lower the dose. In many, many cases, I mean, the majority of cases of tremor, slow moving, shuffling gaits, stoop posture, and that sort of thing, the majority of drug-induced Parkinsonism cases are due to an unnecessarily high dose of medicine. So we can usually start to back down the dose, and that's a way to resolve it. And a long-term, I mean, you can prevent it from happening by starting low and going slow. And as a long-term solution, just, maintain people on lower doses. If needed, prescribe a different medicine with less dopamine interference, or as well, prescribe one of these three medicines as an ongoing basis. In my view, the least desirable option, but there may be circumstances where it does make sense. Tardive dyskinesia. Bullet point number 2, there are some medicines which are approved by the FDA specifically intended to ameliorate the symptoms of tardive dyskinesia. It's best if you can just not give a person that in the first place. And we know that minimizing the total lifetime exposure to these medicines is the way to minimize the risk. And so we can minimize the risk by not prescribing antipsychotic medications unless they are necessary. Reviewing the ongoing need for antipsychotic medications. So for example, if a person comes to us with recurrent major depressive disorder and is not getting better with treatment, you can prescribe a so-called antipsychotic medication to boost the response. It's wise to then see if we can stop that medicine so that we don't have a person unnecessarily exposed to that kind of drug. In cases of schizophrenia, there is some portion of people, maybe between 5% to up to 30%, depending upon the study, who may ultimately succeed with no medicine down the road. But the majority of people will need at least some medicine. Typically, they're not going to need as much medicine to maintain remission as they did to cause remission. So it's a good practice to always try to find the lowest effective dose. That's how we can minimize TD risk. If it does occur, then of course we can use on-label medication, and there's a host of medications that have been fairly well studied that we can use off-label for the treatment of TD, and we can also switch to some other medicines, among them clozapine, to try to further resolve it. So elevated prolactin level, aka hyperprolactinemia. This is, we can lower the dose, we can try a different medicine, and we can also prescribe typically tiny doses of aripiprazole, aka Abilify, are quite effective for this. We can prevent the occurrence by, well, choosing aripiprazole as the first choice of treatment when it's feasible and possible. And if we can't use aripiprazole, or the person is getting a fabulous response with some medicine that does cause hyperprolactinemia, we can look at lowering the dose, or we can co-prescribe a bit of aripiprazole. We may or may not want to look at other medicines to replace it, but it is among the options that we have. And again, this is not going to be on the quiz, and also there's not going to be a quiz. But I'm saying you don't have to memorize these things. I'm just illustrating this to tell you that recognizing side effects is good because we have ways to prevent or treat. And I just want to, put some bullet points on the fact that we can treat or prevent these things. Secondary negative symptoms, like I said earlier, it's impossible to say which person with the schizophrenia syndrome has endogenous or disease-caused secondary negative symptoms versus who has those symptoms that are due to too high of a medicine dose. There's no clinical way to do it. But it does raise suspicion of medication side effect when doses are at the higher end of the approved dosing ranges. And if people are given antipsychotic medications at doses that exceed them, and they're having reduced motivation, reduced range of emotional expression and so forth, then looking at that high dose as a possible cause certainly is worthy of consideration. And probably it's a good idea to consider gradual dose reductions to find a lower dose that it can still maintain efficacy. Metabolic syndrome, again, weight gain and so forth, I write here, like TD, it is easier to prevent than to treat. So to prevent, we would, as a first choice, prescribe a medicine which has a statistically lower likelihood. I want to emphasize that, statistically lower likelihood, because even though these are all on the low tier of risk, there are some people who will experience them, who will take them, who experience significant weight gain. So these just have a decreased odds. They're not a guarantee, but the odds are very much more favorable for minimizing weight gain with this group of meds. Diet and exercise do work. Not everybody's interested in doing it, but I think part of that is on us to explain or present or walk through and talk through what are the obstacles in a person's life that may present barriers to practicing better diet and exercise. And it may be a selling point that studies for exercise, a ton of studies, and for diet, a few. Diet's just not studied as well as exercise. But both interventions actually reduce the symptoms of schizophrenia. So healthy diet, and especially by engaging in regular physical activity, there are loads of benefits just to that. And among them, they can reduce the risk of weight gain from medications. There's a teeny tiny number of papers that speak to a possible benefit of melatonin at reducing the pace of weight gain or helping people lose weight. Tiny number of papers, but again, a medicine with not a whole lot of side effect risk. And also these papers suggest that melatonin may have additional benefits on primary schizophrenia symptoms. I want to emphasize tiny literature though. Metformin has a giant literature to say that it can be helpful, statistically average speaking, of course, at reducing weight that has been gained or preventing weight gain that comes in relationship to antipsychotic drugs. So it is, again, with a lot of data to support it, I think it's helpful for every prescriber to know about it, maybe even to prescribe it themselves, and certainly to know somebody who's comfortable doing it. Because it has a ton of data and it's reasonably effective. Smaller number of studies, significantly smaller studies, but much bigger effect has been attributed to a drug called liraglutide, which goes under the brand names Victoza and Saxenda. And actually, as the brand Saxenda, it has FDA approval for obesity treatment or for use in people who are overweight with some risk factors like hypertension. And again, tiny number of studies, or much smaller number of studies, but very well-designed studies, and showing a very large effect size. So it is, again, worthwhile to either, this would be, I think, a stretch for many psychiatric providers, but to learn about how to prescribe it yourself or know somebody who will prescribe it, and then do battle with the insurance company to get a rather expensive medication, but still with one that has FDA approval and strong effect size. So finally, so that's, again, that's just to point out we have solutions for all these things, and we need to make sure that we're aware when they're happening, and then help our patients get the discussions with their doctors, either the psychiatrist or a general medical practitioner, to try to address these things. So this audience, again, is, I understand, primarily not prescribers, but anybody, parent, friend, non-prescribing clinician, can help by, you know, encouraging patients to discuss their side effects. Again, people, not a small number of them, are just very afraid to talk with us about their side effect experience. Or talk with them about, you know, if you were to talk with your doctor about this, what do you think would be hard? What, you know, what kind of things do you imagine he or she will say? Or what, you know, what are your fears around that? So try to understand what are their barriers or impediments to discussing problems with their care with their providers. You know, and in this case, you know, peer support can be very helpful as well. And I think it's, you know, I wish this was more commonly known, but as I say, the purpose of medicine is to give a person a chance at an awesome life, not to give them marginal benefit with a lot of side effects, because, you know, that's just miserable, and nobody wants to sign on to a treatment that is just marginally effective and side effect prone. So in other words, we all want our patients to thrive, and medications are tools to try to help that happen. There are many options. So letting them know that their comfort is a priority and is what you would want for yourself or somebody that you like, you know, therefore encouraging them to ask about it. And I would encourage you, you could also, in your teams, talk with your prescribing clinicians and ask, what do you think would be the most convenient way to alert you to side effect concerns, and or develop some sort of practice or informal policy in your teams around how you can translate suspected side effect experiences or identified ones to make sure that they do get brought to attention, and that there's some satisfactory resolution to, you know, to all the stakeholders involved. So thank you all for your attention to this today. I will now stop that, and we'll